Let's crack on with the next lectures post-lunch, and I'd like to introduce two moderators to the stage, Dr. Tanya Pereira, consultant cardiologist, and Dr. Tisara Samaravikrama, consultant cardiologist, for the topic on complex PCI.
Professor Gambhir, it's a pleasure for me to actually introduce you to for this particular lecture. Dr. D.S. Gambhir is a professor who's working there in Kailash Hospital, Delhi, and he has a lot of first into his account. He has actually made one of the drug-eluting stents in India for the first time. And he's a well-known interventionist and a well-known excellent teacher. And I don't think that we need any further introduction with regards to Professor Gambhir, especially for the Sri Lankan cardiology community, because he has been to Sri Lanka several times. So over to you, Professor Gambhir.
Well, good afternoon once again to all my friends in Sri Lanka, to both the chairpersons. Well, I was asked to speak on complex cases of left main bifurcation PCI. And as all of you know that PCI has been established as an alternative modality of treatment to bypass graft surgery in patients with the left main bifurcation stenosis. And it has now achieved a class 2A indication in some specific subset of patients with left main bifurcation stenosis. Well, I started doing left main stenting way back in 1996 when I was Associate Professor of Cardiology at GB Pant Hospital in New Delhi. And this was my first case, which I will not go into the details, a ostial stenosis in a young pregnant woman who was 38, and we successfully did her angioplasty, putting in a stent at the ostium of the left main coronary artery. In the first 10 cases we did, the second case was like this, where there was a very high-grade eccentric stenosis in the body of the left main, which was treated by directional coronary atherectomy and then put in a bare metal stent. Well, for ostial and shaft stenosis, there's no in-hospital mortality. The restenosis rate is very low. So there is no doubt that it is an effective alternative and even better treatment strategy as compared to bypass graft surgery. But what about DES for the distal left main coronary artery bifurcation stenosis? Well, that's a real challenge. And as we understand that the left main distal bifurcation stenotic lesions, they comprise almost about 2/3 of all cases of left main coronary artery disease. Certainly technically very challenging to treat, and whenever possible, it's good to do a single stent strategy because of fewer adverse outcomes compared to the two-stent strategy. Well, there are, however, cases where elective two-stent strategy should be planned right from the start of the case. And those cases are if there is a significant stenosis which extends into both the LAD and LCX, that is Medina class 111. If there's a large size of LCX branch with a significant area of distribution or so-called dominant circumflex. And if in the assessment of the interventional cardiologist, the loss of circumflex could result even in hemodynamic compromise and fatal complications. And lastly, if the stenosis in the circumflex extends beyond 3 to 5 millimeter of its ostium, it's better to do a two-stent strategy. Well, in the last 16 years, this is my personal experience of nearly 570 cases of left main angioplasty. And you can see here that 95% of these cases were elective and 5% were emergency. A two-stent strategy was used in almost more than two-thirds of the cases, so 71%. We did three-stent strategy in 13 out of these 570 patients. Angiographic success was very good, more than 98%. We had our own list of minor complications or a small number of complications, which included, of course, 6 deaths, MI, and the follow-up, of course, as we can understand in our countries are not very accurate. Now, what is a complex left main bifurcation stenting? Now, that's purely, I think, besides the anatomical, physiological, and hemodynamic factors. I think I would say a complex left main bifurcation stenting is purely dependent upon the experience and expertise of the operator and the availability of the hardwares, the center where he's working, the backup support, and all those things. So in my experience, I call these as complex LMCA bifurcation stenotic lesions. One which are calcified, as you can see here, those patients who have got a left vein bifurcation stenting and have come to you with a bifurcation instant restenosis and STEMI like this, where a patient has come in a collapsing state with total occlusion of the left vein. Then we have got left vein trifurcation or quadrification like this, pan left vein, and this is another case which we did live. You can see here that there is a pan stenosis of the left main coronary artery which extends into both the branches, and there are diffusely diseased both the branches. And then LMCA with severe diffuse disease in the downstream vessels. In my experience, I feel that all these are really complex lesions, and they should be done only in the hands of very experienced and operators. Now, coming on to the main talk that I have to deliver today, a case in box of left main complex left main bifurcation stenosis. So I have picked up three cases. One is a intrastent restenosis, the second is a highly calcified left vein, and third is a trifurcation stenosis. The first is a 70 years old gentleman. He had a past history of coronary artery disease and underwent primary coronary intervention of LAD almost 8 years ago. He presented with the angina on exertion class 3. EKG showed left underbranch block. His myocardial perfusion scan was positive for ischemia in the LAD territory, and echo showed a left ventricular ejection fraction of 40%. He underwent an angiography in January of 2019, it's almost going to be 2 years, which I'm going to show you very soon. He had a distal left main bifurcation stenting, including the ostia of the LAD and circumflex, and an instant restenosis in the LAD, which was starting right from the ostium of the LAD. So the plan was to do a PCI, including rotablation of LMCA, distal bifurcation stenotic lesions, plus rotor stenting of the LAD. Now, this is his angiogram, the left coronary angiogram. You can see here that there is a distal left vein, which you would appreciate much better in the aleocaudal view. There is a moderate degree of stenosis, instant restenosis, starting from the ostium of the LAD. And then there is a long instant restenosis in the mid to distal segment of the LAD with TIMI2 flow. The LCX also has got a significant stenosis at the origin. It's a large size dominant circumflex, and the RCA was non-dominant small vessel. Now you will see in the aleocaudal view, what I said is much better appreciated in this view. There is a intrastent restenosis which is starting from the ostium of the LAD. There is a high-grade stenosis at the origin of the circumflex and distal left main bifurcation stenosis. So what we did was we did a IVOS assessment and then planned to do a rota ablation followed by a first distal LAD stenting and then LMTA bifurcation stenting using DK crush. I have taken away some of the steps of the DK crush because when I read the program, DK crush was discussed in detail in the previous sessions. So I have taken out some of the steps of the DK crush, although this recording was done as a live case with all the steps of DK crush. So when we did the IVOS, you can see the LAD, this is the ostium of the LAD, which had a stenosis of 70% with a minimum lumen area of 4. Then the ostium circumflex had a minimum lumen area of 2.6 with a instant restenosis of 75%, and distal LMCA was having a stenosis of about 51% with a minimum lumen area of about 8.64. So since it is a ostial LAD and since there is a ostial circumflex, and I always and there is a quite a bit of intimal hyperplasia, I always first do a plaque modification, debulking in cases of ISR with a rotablation or a cutting balloon, depending upon the situation. But in this case, we choose rotablation because the patient also had a long interstent restenosis in the mid to distal LAD. So we did a rotablation of LAD using firstly 1.25 millimeter burr. And then we went ahead and did a 1.5 millimeter burr rotablation of the distal LMCA bifurcation. And this was taken down, as you can see here, right into the mid to the distal LAD. So this was followed by the rotablation of the LCX ostium. The same wire was, negotiated into the circumflex, and then we did a rotablation of the LCX ostium. And this was followed by serial balloon dilatations of interstent restenosis in the LAD before delivering of the drug-eluting stent. You can see here the balloon in the LAD starting from the distal coming backwards into the proximal part. And this was followed by the delivery of a resolute onyx stent in the distalmost part. 2.5 into 34 millimeter long stent was delivered. As you can see, the stent is being delivered in the stent in stent. There was a previously also a stent in the distal part, and here the stent has been deployed. And this was followed by deployment of another long DES, which was again resolute onyx 3 into 34 from the proximal end protruding into the LMCH. Since it was a DK crush, I hope that everybody understands how DK crush is done. So we have a wire here in the LCX. This stent has been taken from the mid to the proximal part of the LAD, protruding 1 to 2 millimeter into the left main. When we do so, we always keep a balloon parked in the circumflex so that we have to crush the protruding part of this LAD stent by pulling the balloon backwards into the left main and then crushing the protruding part of the stent. So after deploying the stent into the LAD, which is now protruding 2 millimeters into the left main, a check angiogram must always be done, which was done in this case. And this was done after several high pressure balloon dilatations of the LED stents. So you can see here that the flow now looks much better. The stenosis seems to be quite a bit of it has been relieved. So we now have to crush the LED stent, which is protruding into the left main. So the LCX balloon was pulled back, and then it was taken into the left main, partly into the circumflex, and then opened up at a moderate pressure, thereby crushing the protruding part of the LED stent. This is the first crush. Having done that, we placed a guide wire through the crushed part of the LED stent down into the LED. The wire in the circumflex always there. Now we opened up the cells of this crushed part and then gradually stepped up the balloons so as to have a kissing balloon dilatation between LED and circumflex. So this is the first kiss. You can see here the first kiss, which is with two balloons of optimal diameter kissing each other. Having done that, we then deployed a DES, which was again Onyx 4.5 into 15. Now the quality of Onyx is that here we assess the size of the LCX was almost about 4.5, and the size of the left main was almost close to 5 millimeter. So the Onyx 4.5 can be taken up to even 5.75 millimeter. So we picked up a Onyx stent, which was placed into the proximal part of the circumflex, protruding back into the left main, and then it was deployed from left main to LCX. And so this was a second crush. Then a check shot was taken to see that the distal circumflex and the LED are flowing nicely and there is no dissection at the distal edge of the LCX stent. Having done that, we then swapped the guide wires. The LCX guide wire was pulled back and then taken from one of the cells of the left main to LC extent and placed into the LED. As you can see here, the guide wire has been pulled back and is being placed into the LED. The jailed guide wire in the LED has been pulled back, and then this jailed guide wire will be transferred onto the LCX. So this is called swapping of the guide wire. Having done that, we then did a second kissing balloon dilatation after opening up the cells on both sides, and then followed by a pot, uh, and this was followed by the assessment of the results. Now it looks to be a very decent, respectable results, giving the circumstances that we were doing with a interstent restenosis and then a left main distal bifurcation. Now, if you see it carefully, I'm sure the participants must have noticed that there is something fishy over here, which bothered us now. Now, if you look at the LED, there is something fuzziness, haziness at the inferior border of the LED, and we kept on struggling to find out what exactly is this. So we took several shots, several views. I'm not going to show you all, but there is certainly something which is happening over here. Now, there is no way with us to confirm what it is. We took caudal view. One of us thought that it is a branch, but then we thought that it could be a leak also. Anyhow, so you can see here, the same thing is visible here also. This is the caudal view. It looks to be a branch over here. So this debate went on for some time, but the patient was stable at this point of time. So, but one of the possibilities and differential diagnosis was a leak from the proximal part of the LED when the high pressure balloon dilatation was done in the LED. So patient was then transferred to the CCU, and after 3 hours, he developed hypotension with a blood pressure of 80 to 90. He developed tachycardia with a heart rate of 120, and echo showed mild pericardial effusion. So that confirmed that possibly we had a leak from the ostium of the LED. Now, we brought the patient back into the cath lab after we realized that he had a small pericardial effusion. But then we were always apprehensive that it may increase and then we may have difficulties. And now you can see here that patient has got marked tachycardia. His heart rate when he was brought back was almost about 135 to 140. And that fuzzy shadow or haziness still continues to persist at the inferior border. So at this point of time, we thought we should put a stent graft over here. So we took a stent graft 3.5 into 16, carefully saw to it that it does not protrude into the left main otherwise or overlies the circumflex origin, because otherwise it may occlude the circumflex. So having done that, we deployed this stent graft at the ostium of the LED. And this was followed by kissing balloon dilatation, again between the LED and the circumflex. So this was a final kissing balloon dilatation, and this was the final result. Now you can see the difference there, that fuzziness or haziness at the inferior border of the LED had disappeared. So this was quite satisfactory, excellent result. Although the flow in the LED is still TME2 or TME2 plus, but then gradually the flow improved. The patient remained asymptomatic thereafter. After 6 to 8 hours, during this time, patient received 2 units of blood transfusion. His hemodynamics stabilized, his heart rate dropped down to 100, and he was discharged after 3 days. And a check angiogram was done after 2 weeks, which showed a TME3 flow. This patient has now been followed up clinically for almost about 2 years. It's going to be 2 years, little less than 2 years, 1 year and 9 months. He's totally asymptomatic and doing all his activities. So this was a very interesting case of left main distal bifurcation with instant restenosis, which was treated first by rota ablation and then followed by a TK crush bifurcation stenting. Then we had to use a stent graft to cover up a small leak from the ostium of the LED. Now, we come to the case number 2, which is still much more difficult, challenging. It's a calcific stenosis at the left main bifurcation in a patient who presented to us with acute coronary syndrome, but in addition had idiopathic thrombocytopenic purpura. Now, that's a very rare combination. Let me first give you a little bit of background. This thrombocytopenic purpura, as we understand, is a bleeding disorder characterized by premature destruction of platelets mediated by autoantibodies. Prevalence is extremely rare, 100 cases in 1 million population per year. What are the problems with the ITP? When you deal a patient with ITP, well, the problem we all know is bleeding. Patients can have spontaneous microcutaneous bleedings, or a patient can have major bleedings, which can be GIT bleeding and intracranial bleeding, or any life-threatening bleeding in 5% of the cases. But ITP with acute coronary syndrome is still rare. So what I'm going to present is a very, very rare case. And the problem is we have to weigh on one hand the safety of the antiplatelet agents, on the other hand the problem caused by the bleeding due to a low platelet count. So it's a very dicey situation, very difficult situation to balance out treatment in such kind of patients. And unfortunately, there are no guidelines or randomized studies to recommend what should be the antiplatelet regime in such patients, what should be the dose of antiplatelet agents, uh, and how long should they be given. Now, this is a gentleman who is 63 years male. He was hypertensive, but no other risk factors. He had a past history of having received a stent in the LAD in 2002. That means almost about 18 years ago. He became partly symptomatic in the year 2009 when he had an angiogram done at another institution which showed his left main coronary artery had 70% distal. I don't have his angiogram, but I was told that this was the report. LMCA was 70% distal, LAD was 60 to 70% ostial, and LCX was diffusely disease. So he went to different surgeons. Most of the surgeons in the city refused to subject him to bypass graft surgery. And patient was also not keen for bypass graft surgery because he was very mildly symptomatic. But then when he presented to us in 2019, he was class 3 symptomatic with angina on exertion and occasional episodes of rest angina. And I'll show you what is rest angina. His ECG on admission this time, which was last year, I think it's going to be almost about a year ago. His ECG was normal on admission, echo was normal, stress echo was positive for ischemia, and platelet counts was ranging between 55 to 61,000. So a low platelet count. Now look at the ECG. This is the ECG during pain. You can see here that there's a marked ST segment depression in the anterior leads with some ST elevation in AVR. And we knew that this patient had a left main coronary artery stenosis, so we were always frightened to see his ECG. But this ECG would settle down with some beta blockers, intravenous beta blockers, etc. And we were waiting because we had to do this case live in one of the conferences. And we also wanted to possibly raise his platelet counts with some specific therapy. So we consulted our hematology department, and they advised that this patient should receive a specific therapy for his low platelet count before undergoing a angioplasty. So he was advised a single donor platelet transfusion of 3 units, anti-D injection once daily, 4,800 microgram over 60 minutes, and then injection solemn withdrawal daily for 3 days, 500 milligram. So with this, he was posted for a live transmission of his case from here to another city in India. And on the morning of his that day, his platelet count was almost about 85,000, sorry. Yeah, so this is his angiogram. Very nasty looking angiogram, heavily calcified distal left main with a very high grade stenosis and also calcific. The stenosis extending into the proximal part of the LAD along with calcification. The stenosis is also extending into the LCX, and see the angle of take of the LCX. Left main goes firstly more towards the LAD and then turns backward for the LCX. So this is a very difficult angle to manipulate. And then the LCX is diffusely disease, and the disease is extending into the ostium of the medium-sized obtuse marginal branch. And then there are some diagonals, etc. So we wired, now first we wanted to do we wired both the branches, which was not a difficult task. And we first wanted to do a IVUS, but unfortunately the IVUS catheter would not get negotiated. So we then did a ballooning of both the sequential ballooning, first of the LED followed by a LCX. And this was followed by IVUS. Now, I forgot to tell you that on the day of his live transmission, this patient in the morning at 6 o'clock, we had to be live at 8 o'clock, developed a severe chest pain with same kind of ECG with 5 millimeter segment depression. So we had to really rush in and take him up on the table, and we immediately put a IABP. Gave him 3 times intravenous metoprolol 2.5 milligram, and by that time, in next half an hour, his pain started settling down. And by the time we had put the patient on IABP, and we were all ready to go to flight. So you can see the IABP. So this is the post balloon result you can see here. And now we were ready to go for IVUS, and this is the IVUS pullback, both from the LED as well as from the circumflex. And these are the IVUS findings. You can see that there is a ISR in the LED with a stent diameter of 3 millimeter and vessel diameter of 4 millimeter. You can see here. And this is at the LED ostium, where the minimum lumen area is 2.5 millimeters square and the vessel diameter is 4 millimeter. It's a large size vessel at the LED ostium. And the distal left main was as big as 5 millimeter with a minimum lumen area of 4.4 millimeters square. So highly calcified LED ostium, and then a stent in the ostium of the LED. So we thought that we should do a rotablation of LMCA to LED and circumflex both the vessels. And you can see here that first the LED and then a rota was done in the circumflex. And then this was followed by deployment of DES in the distal LCX first. So we first treated the distal LCX. So in this patient, we wanted to do a tap technique. So we first deployed a stent in the distal LCX going on to the origin of the obtuse marginal branch. And this was followed by deployment of DES from LMCA to LED. This was a onyx stent, again, because of its potential property of becoming bigger in the left main if you wanted to become big. So we deployed a 4 millimeter into 26 millimeter long stent starting from the ostium of the LMCA, going into the mid portion of the, going from the ostium of the LMCA into the mid portion of the LED. So this stent was deployed, and then and you can see here that there is a post LMCA to LED stent result, but we have still quite a big of or a large segment of the LED mid to distal part of the LED, which is disease within the stent. And we had measured the area, it was almost measured the diameter of the vessel, it was almost about 3.5 millimeter. So we then deployed another Onyx 3 into 34 overlapping with the previous stent into the mid LED. And this stent extended up to the distal part of the LED. And now you see that LED looks big. We have still not done the post-stent high pressure balloon dilatation. And then we did a tap, kept a balloon parked in the left main and took a very short stent. This was a Onyx 3.5, I believe, or 4 into 12 millimeter taken and deployed at the ostium of the circumflex and using a tap technique. And this was followed by kissing balloon inflation and then a pot and then IVUS. Now you can see that post bifurcation stenting, the distal left main vessel diameter was 5. And you can see that the plaque burden had reduced to almost 48%, and the minimum lumen area was as big as 12.3 millimeters square, which is very acceptable. And this is the final angiographic result. So from a vessel which was very heavily calcified and was diffusely diseased right in the left main to LED instant restenosis, and then diffusely disease in the circumflex, it was a very good result. So when we reviewed the literature, we found that between 1999 to 2015, that is over a period of 16 years, there were 17 studies with 18 patients and who had undergone 12 PCI. The mean age was close to 60 years, and single vessel disease was treated in 13. This I am talking of the literature of patients who had ACS with ITP. Single vessel disease in 72%, and then only one patient had undergone a triple vessel stenting. Uh, LMCA was done only in one case out of these 18 patients. Platelet count in this entire study series was 78,000. So in nutshell, this is one of the rarest of the rare cases. In conclusion, I can say that PCI is safe and feasible. One has to weigh the risk benefit of PCI versus antiplatelet agents, and that must be clearly defined and explained to the patient. There is no standard guideline reported in the literature for antiplatelet regime in these patients. Dual antiplatelet therapy with clopidogrel plus aspirin is effective in preventing stent thrombosis. It is advisable not to use very strong antiplatelet agents like ticagrelor or prasugrel. Now, lastly, we are just left with 5 minutes. So I am going ahead with just quickly on a left main trifurcation stenting complicated by left main dissection. Now I'll skip off some of the literature. Well, left main trifurcation is preferred, CABG is preferred treatment of choice in such cases. However, technically it is possible to do a left main trifurcation stenting, but very challenging and should be performed by highly skilled operators. These are the two types of left main trifurcation stenosis. One, type A, where the left main body is involved and the stenosis extends for variable distance and in one, two, or three, all the three branches. And in type B, when the main trunk is spared and the stenosis extends into all the three branches. Well, these are the indications of PCI in patient at high risk for CABG, patients who refuse CABG, if there is a need for an emergency or emergent revascularization, and highly experienced operators. I'll skip the clinical profile. This is a 66 years male who had previously undergone a stenting of RCA twice in January 2013 and 19. And he had, now this is the angiogram. Now you can see here that he had a quadrifurcation. This is LED, which you would see better in another view. That's a moderate degree of stenosis. Then this is a ramus branch, which has got a moderate stenosis, a small obtuse marginal branch, and then the LCX. All these would be better visible. You can see that LED is disease starting right from the ostium. And I'll show you aleocaudal. Now, this is after wiring. You can see the LED has got a moderate stenosis. If you see the distal LED, then the ramus has got a moderate degree of stenosis. And now you can appreciate this highly eccentric stenosis in the ostium of the circumflex. So I'll quickly run through. The first thing is we did a SKS technique to do a LED LC extending using SKS technique. Two stents were taken down. The guide wire in the ramus was jailed, and thereafter the jailed guide wire was withdrawn, and we did a high pressure first sequential and then simultaneous balloon dilatation with a good result. Now, since we had to do a trifurcation, tri-kissing balloon dilatation, so we put another guiding catheter from the left groin, and from the left groin, we took one balloon and one stent, and which was taken, the balloon was taken into the circumflex, and the wire was negotiated through the stent, which was deployed into the circumflex, and then taken into the ramus branch, and then we threaded a stent over it. Through the other guiding catheter, which was already placed, we had kept it a balloon on this wire in the LED. So this is what it was. And then finally, we had done a final kissing balloon inflation on all the three branches. You can see us using two guiding catheters. And this was the result after triple vessel stenting. But the story starts now. This patient had a dissection at the body of the left main. So we did a IVUS to confirm. I'll not go into this, but IVUS, I'll skip some of these runs of the IVUS, which will show that the LED stent is well opposed. But if you see that there is a horseshoe dissection in the body of the left main, and this is extending right up to the ostium of the left main coronary artery. So we therefore took another short stent and deployed it from the ostium of the left main, and using a high resolution fluoroscopy and stent boost, we took the distal part of the stent and aligned with the proximal part of the double barrel, which we had created by putting two stents using SKS technique in the left main. Okay, so we therefore saw to it that this stent does not protrude into any of the two stents deployed earlier, either into the LAD or the circumflex. Otherwise, it will crush the other stent. So this was done, and this was followed by a IVUS, which led to a complete dissection, was completely sealed. You can see here, and this is the final angiogram. You can see here that nice result. The dissection, which was very nasty looking in the left main, has been sealed. A very nice ostia of the LAD, ramus, and the very nice ostium of the circumflex. And this is the final result. So, ladies and gentlemen, left main trifurcation is indicated only in exceptional cases, should be done only by very highly experienced operators. One should wire all the three branches followed by segmental balloon dilatation. Stenting should be done in order of significance of the various branches. A final triple kissing balloon dilatation is mandatory in all these cases if it's feasible, and this is feasible by using only two guiding catheters. With that, I stop here because my time is over. Thank you very much for your kind listening.
Professor Gambhir, I hope you can hear us. Thank you very
Yes,
much
I can hear.
for those three excellent lectures. We have quite a few questions that have kept coming from our audience as well. On your first case, I'd like to ask you whether you consider drug-eluting balloon into that instant restenosis instead of actually going for a full metal jacket, as it were, from left main to the distal most point of the LAD.
Now, to answer your first question of using a drug-eluting balloon, firstly, I am not a great supporter, or I am not a supporter at all of the drug-eluting balloon, and I don't like this concept at all. You see, the basic principle has to be understood that for getting a good result from a drug-eluting balloon, one has to first get a good result from a plain balloon. And in my experience, if a patient has got a intimal hyperplasia with significant intrastent restenosis, it is almost impossible. I repeat, it is almost impossible to get a good result with plain balloon angioplasty. You would always end up in leaving a 30 to 40% residual stenosis unless you do a debulking. So therefore, if you are leaving a residual stenosis of 30 to 40%, and over and above that, you put a drug-eluting balloon, let me tell you in plain, simple words and emphatically that the patient will come back with a restenosis. Because one of the principles of getting preventing a re-stenosis is that you must get a residual stenosis of less than 10% if you want to have a, or if you want to prevent a re-stenosis in patient with instant restenosis, which is not feasible with instant restenosis. So therefore, either use a debulking technique and then put a drug-eluting balloon. That may still be possible. But if you are not doing a debulking, then along with a balloon and then putting in a drug-eluting balloon, I don't think it will really work. So therefore, I am not a great promoter of a drug-eluting balloon. Therefore, I don't use, and that too for such a long reason.
Also, sir, we noticed that there was a dominant LCX and you rotablated that. And is it normally a practice not to put in a temporary pacing lead, even if you were rotablating a dominant LCX?
Not in the LCX. Even if it is dominant, I don't put a temporary lead. But if I am doing a rotablator in RCA dominant, I always put a temporary, not in the dominant circumference.
So we have some questions from our audience as well, sir, regarding the DAPT strategy in your patient with ITP. Would you actually give antiplatelets with platelets counts less than 50,000? And what would be your heparin dose?
Well, the dose of the heparin, we normally give a standard dose of 7,500 international units in almost all the patients, unless the patient is extremely low weight. But in this patient also, we gave the same dose of 7,500 international units of heparin, which was an unfractionated heparin. And this was followed by a standard dose of clopidogrel and aspirin, which we give 75 milligram twice a day of clopidogrel for 1 month, followed by 75 milligram once a day, and aspirin 75 milligram twice a day for 1 month, followed by 75 milligram once a day. But in this patient, we cut it down to 75 milligram of each one of them right from the beginning until the time we have followed him up. He has been now followed up for about 8 months. But let me tell you honestly, he has again started getting angina. So there is a possibility that he might have developed a restenosis. But he never had any bleeding, and his platelet count is now varying. He came last for the visit in the OPD some about 2 months ago. His platelet count was about 90,000 to 1 lakh. Most of his platelet counts are in the range of 90,000 to 1 lakh.
Professor Gambhir, there's another question from one of our colleagues. Is it all right to gel an LED wire between the two metal layers? And ideally, should you have removed the LED wire in your first case when you deployed the circumflex stent?
Well, in the DK crush, the first patient you're talking about, we jailed the LED wire. I see absolutely no problem in jailing a LED wire or a circumflex wire in any of the patients. There is absolutely never a problem. In fact, I don't remove the wire at all unless I have rewired it. You see, in this case, it possibly may not matter. But if you're doing a tap technique, or if you're doing something where you have jailed a wire, so sometimes what happens is that when you pull out the wire, the side branch starts occluding. So therefore, it is always good to first wire it, let the jailed wire remain there, and pulling out the jailed wire is never a problem. Never a problem. Let me assure you, it is. I have yet to come across even a single patient where we have not been able to pull out a jailed wire.
The question was how frequently you jail the wire between the two metal stents in case of where you have to.
No, between the two metal stents, like for example, the two metal stents are only in patient with possibly the keloid technique. Otherwise, you generally don't have two metal stents in the main vessel. Generally, you don't have, isn't it? So,
Yeah.
keloid technique, I must admit, I have done out of these 600 cases only in 3 cases. So I don't do keloid technique, but keloid technique, so I can't answer this question whether you can jail the two wires in the two stents, one wire in the two metal stents. But in one metal stent, there is never a problem.
You had any problems with the crossing after the crushed stent in a DK crush situations?
If you are careful in protruding only 1 to 2 millimeter, I never had any problem out of, I think we must have done almost about 55, 60 cases of DK crush
Thank
by
you.
down. We have never had a problem.
Professor Gambi, do you have any tips for us on shaping the guide wire when we are recrossing the crushed stent in the DK crush?
Well, I think the only tip is that first thing is you should use the conventional wire, and the question that you have asked is shaping. Now, shaping purely depends on the size of the main vessel. It is not dependent upon how much angle you should give it. But it is good to give a secondary curve on the wire if you've got a large left main. So primary curve should be short and not more than 30 degree, because if you give a very sharp angle, then it catches the struts. So give a very shallow angle, 30 degree, 40 degree, and then give a secondary curve, which is a bigger curve if you are in the large left main, and then go ahead. It doesn't really create a problem. But don't give a very sharp angle, because a sharp angle curve would likely to get caught into the struts of the stent.
Professor Gambi, thank you very much. That was a very interesting and session, and we all enjoyed it. And we'd like to thank you in behalf of Sri Lanka Heart Association.
Sri Lankan Cardiology Society for giving me this opportunity to present some of my so-called interesting cases which were reasonably difficult, I must say.